We will indeed have the opportunity to raise questions. Is there anyone in the room who likes to ask a question? Is there a microphone, or otherwise speak loud and tell your name?
Hi, I'm Dr. Chakravarti from India.
Yeah.
I want to ask you, how do you adjust the protein intake based on urea-creatinine ratio?
So,
You're more of an expert than I am.
oh, actually, we don't do it yet because we don't know exactly what is the threshold, but we are now to do a retrospective study on many patients because we have the data, and we have to find optimals. What we've seen, when you build up the proteins in the first few days, the UCR goes up, but that's normal. The percentage will be discarded. But then when you are in a stable situation, you can try to increase your protein dose, and when it doesn't go up, probably it can be handled metabolically. When you see a rise in the UCR above a certain threshold, but we have to find it in critically ill adults, then maybe you have to reduce the protein intake. And what we noticed, whenever there is an insult, a surgery, inflammation, whatever, it goes up. So it could mean that at that point, we have to reduce the protein and maybe also energy intake. Because also this endogenous energy production, what starts on the ICU admission, maybe it happens again after a second insult and inflammatory response. We don't have data on that endogenous energy production in late phases, I think.
Yes, please.
So I'll give you that patient with a BMI of 82, which is a real patient. Her creatinine is low, showing to me that she's sarcopenic. Now, fortunately, she has a normal kidney function, and that I can take away. And so what I do is I challenge the patient. And as I increase my protein, if the urea is not climbing, and again, I have to be very careful on fluid management, etc., then I continue to challenge the patient. Now, in that case, I'm restricting her calories severely. I'm doing 800 calorie restriction, non-protein calorie restriction. And one of the things that you see is the dramatic effect that reduction in calories, particularly carbohydrate intake, in these specific patients and morbidly obese patients has on minute ventilation and CO2 production. And they actually start breathing more comfortably, and they actually do better. And the other thing that happens is that their affect improves. And so they start smiling. They want to participate in physical therapy. And I think it's a fertile area for more research.
Maybe I can add one small aspect. Many patients, about 1 out of 5 patients has refeeding syndrome in the first few days of ICU admission, and we know we have to restrict calories in those patients. Sometimes some intensivists believe that we have to supplement proteins then, because you restrict the calories, but you give the proteins. And we published, I think this week in Clinical Nutrition Aspen, that the mortality in refeeding syndrome is driven by the protein intake and not by the carbohydrate intake. So it's a retrospective study, but you can read it. So also be careful with proteins in refeeding syndrome.
So I think that we can summarize that in if there are many beliefs and thoughts and physiological reasoning, sometimes the clinical trials, the prospective clinical trials, do demonstrate the opposite. And that's an issue that was really quite spectacular and dramatic in the field. I may have a question for both of you. We know that proteins are hopefully used to rebuild muscles. How to integrate the intensity of physical activity into the prescription of proteins, and what about bolus proteins after physical exercise? Maybe Juan first.
Yeah, and I think what is important, and I think Arthur alluded a little bit to that, or one of the previous lectures, is pulse of protein intake is anabolic when the patient is metabolically ready. And that becomes really important. Is the patient metabolically ready to receive a challenge of protein and then start building protein? And at that point, adding physical therapy becomes a really, really important thing. Now, we start with early physical therapy, and there's data that suggests that that's good. But what I think really makes a big difference is once we start really a process of challenging the patient, then the hope is that we get a far better anabolic response.
Yeah, maybe a few additions to that. First of all, exercise is a catabolic event. You have to consider that. So don't do it when the patient is in a severe inflammatory status with severe metabolic disturbance. So in all the studies, you see that the aggressive exercise strategies are only maybe 1, maybe 2 days earlier. And of course, we try to get the patients out of the bed, in the chair, on the ventilator. But to do real exercise is the moment that the sedation has stopped, and it's a late phase of critical illness in most patients. So don't overdo the exercise in that phase. Second, one of my postdocs, Imre Kouw with Leanne Chappell from Australia, showed with labeled proteins that the absorption of proteins, so the amino acid absorption after whole protein meals in critical illness on day 4 is normal. And the abundance of amino acids in the blood is also okay after a meal, but then the problem comes, it's not going into the muscle cells. So they took muscle biopsies, so there is what they call anabolic resistance. So in that situation, you can give a lot of proteins, but when it's not transported into the muscle cell, there will be no protein synthesis. It doesn't help. It will lead to oxidation, urea, and probably metabolic problems, especially, of course, in those patients with AKI, because they cannot handle the urea. So I think, yes, exercise is very important. I think these electrostimulation studies in ICU are a little bit disappointing, because those patients who need it the most, with the high SOFA scores, do not respond on the electricity with a contraction. And the only way to have an anabolic signal in the muscle is contraction. So it's not the electricity, it's the response to the electricity. So I think in most patients, in a later phase, you can start exercising. And when it's possible to exercise, you can probably increase the protein dose, because also insulin resistance will resolve when you do exercise. So I'm a believer in the combination of nutrition and exercise. But I think we have not to do too much in the early phase of hyperinflammation in the ICU.
I think that time is running, so it's almost time to close the session. I would like just to finish with a suggestion or consideration, which can be seen as maybe philosophical, or I think that we should distinguish between the safety outcomes with nutrition, which are the complications, maybe life-threatening complications. So an increased mortality would be a safety issue, while the efficacy, we need to be humble. And if we can improve something with nutrition, it should rather be muscle function, functional autonomy, maybe immune response, but should not expect to save lives with appropriate nutrition. But just to integrate nutrition and just well conceived, well designed and personalized nutrition in our care plans. With that, thank you very much. Thank you again for Nestlé for having sponsored this session, and enjoy your time in Brussels. Thank you.